And now let me introduce our speaker today. I'm very pleased to introduce Lisa Ellinger, whose title is Director, Office of Strategic Health Policy at the Wisconsin Department of Employee Trust Funds. That's the office that administers the health and life insurance programs and some other supplemental benefits for approximately 250,000 state and local government employees in the state of Wisconsin. Lisa's been with ETF since 2008. One of the responsibilities of her office is the staffing of the Group Insurance Board, which has been considering our health insurance coverage for recently and has been much in the news. So if you want to know something about state employee health insurance programs or any other programs, our speaker today is the expert to ask. I might point out that Lisa has lots in common with us. She is also a state employee. So with respect to health insurance, she's in the same boat as all the rest of us. She's an alumna of the University of Wisconsin-Madison. She got her bachelor's degree in journalism and political science from UW-Madison, and then went on and earned a master's degree in public administration from the La Follette School of Public Affairs. It is a great pleasure to introduce Lisa Ellinger.
Thank you for the lovely introduction that kept the bar of expectations nice and low. I know lots of stuff, that's great. Thank you. I have to start by saying I'm absolutely thrilled to be here today, and the timing couldn't be better. As I'm assuming a lot of you read in the paper, our board made some pretty significant decisions on February 8th. And I think we've already heard loud and clear that our members have a lot of questions, and I think the more we can get out and talk to folks and hear their questions, the better that helps us develop our communication strategy. So we really I appreciate the opportunity to be here today. I also wanted to introduce Arlene Larson, who's down here in the front row. She will be kind of capturing thoughts on things we might want to add to our communication materials, and also any to-dos or follow-ups that we want to take away today. And Arlene is also a Medicare expert. So before I get into trouble misspeaking, I might turn to her if any questions get a little bit advanced. So thank you again for the opportunity to be here today. So starting out, we're just listing our objectives for today. I hope this fits pretty well with what you were expecting or hoping to learn today. So I want to make sure that you walk away understanding what those recent decisions were that the Group Insurance Board made, and what changes we are implementing for 2018. We also want to make sure that you as members understand how those changes impact you. We want to make sure that you're aware of the next steps in the weeks and months ahead, and then we want to leave you with different ways to make sure you can stay informed and get information about your benefits. So our agenda follows that pretty closely. I'm going to start with, we call it e-learning, but a little video module that we put together that provides a nice high-level overview. And then I also want to spend some time talking about kind of the history over the past few years and how we ended up where we are today, because there's been a lot of discussion and analysis over the past few years. This proposal and these ideas didn't just appear overnight. And so I think it might be helpful to walk through that history. And then, as I said earlier, we want to make sure you understand how these changes impact you. And we'll be talking both about pre-Medicare retirees as well as those who are in the Medicare program. And like I said, want to make sure that you know how to get information about all of this and your benefits. And I'm really looking forward to what I am sure is going to be an engaging question and answer, given my previous appearances with this group. So let's start with the E-module, and yay, someone who knows what he's doing, that's always good. So maybe before we start this, if I could just explain what this is. Over the past year at ETF, we've tried to, oh, that's okay, I can talk after. You're great, thank you. So over the past year, we at ETF have been trying to pilot this new communication style. I called it e-learning before, but they're just quick little online modules that are meant to deliver information at a high level, stay away from technical jargon, be 5 minutes or less, be convenient and easy for our members to understand. And like I said, we're really focused on 5 minutes or less. We know people are busy, and so we're trying to up the chances that you might actually take time to view these modules. We do appreciate the fact that not all of our members are online, and that may not be the preferred communication, education vehicle for you. So this is not meant to replace our written communications. It's just meant to complement it and be another way to get information out to people. So again, I think we just released this last week. I think it provides a nice overview about what we're going to talk today. So we'll start with that.
Last time we checked in, the Group Insurance Board was considering whether or not to move the state group health insurance program to a self-insurance model. Remember, self-insurance simply means that instead of the state paying health insurance companies a fixed premium, ETF will use third-party administrators to pay healthcare costs directly, as they currently do with 3 self-insured benefit programs: pharmacy, uniform dental, and the statewide It's Your Choice Access Plan. Back in February of 2016, the board decided to issue a request for proposals to evaluate self-insurance and the possibility of regionalizing the program. In November 2016, they first saw the results and continued to discuss them through late 2016 and into early 2017. After much deliberation, the board reached the decision to both regionalize and self-insure the program. Why regions? The board wanted to increase access to quality providers throughout the state, while ensuring members can keep their current providers. They also wanted to streamline program administration, simplify program information for participants, and control costs. Currently, the health plans choose where they will provide services. In the new program structure, the state will be separated into 4 coverage regions: North, South, East, and West. Health plans will be required to serve the entire region. The board chose vendors that scored well in the areas of quality measures, strong health management programs, and cost effectiveness. The board also approved a self-insurance model. This model is prevalent for many states and other large employers. In fact, 46 states, including Wisconsin, self-insure at least part of their employee health benefits. Additionally, 94% of employers with more than 5,000 employees self-insure their employees' healthcare coverage. If you need a refresher on self-insurance, check out the e-learning entitled Self-Insurance in 5 Minutes. A self-insured model will help ETF and the board understand participant health needs. New agreements will require health plans to meet high performance standards in the areas of quality care and customer service. And don't forget the bottom line: cost savings and transparency. The board estimates taxpayer savings of about $60 million from 2017 to 2019 without reducing member benefits, with similar savings expected in future years. This will help control future premium increases and will help to maintain the current benefit package. Before we get any further, let's explore some questions you may have. Are my out-of-pocket costs going to increase with self-insurance? No. The board decision to self-insure does not increase the amount you have to pay when you go to the doctor or the pharmacy. Does it mean I have to pay more each month for my health insurance? No. While healthcare costs in general are on the rise, a self-insurance model does not mean higher monthly premiums. Self-insurance only relates to how claims are paid. Will I be able to stay with my current healthcare providers? Most likely, yes. The analysis has determined that 98% of current providers will continue to be available in the new program structure. This number is also expected to increase. How will I know which plans cover my primary care doctor and the rest of my healthcare team? ETF will provide information and plenty of time for you to make a decision about which plan to choose for 2018. While it might seem as though these are big changes, you will not see a difference in how your healthcare is delivered. The biggest change for you may just be the insurance card in your wallet. These changes will take effect January 1st, 2018. Our priority is to keep you informed about your health benefits. Watch for more e-learning this spring on how the board decisions will affect you. Also, remember to stay connected by signing up for ETF email updates on our website and follow us on Twitter at WI_ETF.
But so what was referenced in that video is the fact that we put out a similar little 5-minute snippet earlier in 2016 that just tried to explain basically what self-insurance is and what it is not. And you probably picked up pieces of that again in that little module that we just played. And so what I'd like to move on to next is how did we get to where we are today, and emphasize the fact that the board has been discussing this concept of self-insuring, restructuring our program for several years. And I just wanted to quickly walk you through the timeline of that analysis. And that's a canned graphic up there, but it's not dissimilar if you were to stack up all the studies and analysis we've done over the past few years. It would probably look a lot like that. So, the first bubble up there is October of 2012. That was the first produced report from the board's then consulting actuary, Deloitte. And I would say 2012 is when the board's interest in self-insuring just started to grow. And it might be helpful just to think back to put that into more of a societal context. So in 2012, the Affordable Care Act was just a couple years old. Some of the fees associated with the ACA were starting to take effect or become more familiar to people. And one of those taxes or fees that was of the most interest was a fee that applied to fully insured plans that the state could potentially avoid paying were we to self-insure. So that was definitely an early motivation for looking at self-insuring our program. I will also remind you back in 2012 that we had fairly recently passed and enacted Act 10, which had impacts on employee benefits, including the health insurance benefit. Just as a reminder, in 2012, employee share of premium contribution doubled. In it was also the first year we introduced co-insurance into our program because we were required to come up with a fixed dollar amount of savings over the biennium. So those were both motivators that led our board and ETF to say we've really got to get a handle on our cost growth because we don't want to continue to reduce benefits, nor do we want to continue to pass along additional costs to our employees and members. So those were a couple of the motivations going on at the time. So that Deloitte study that was produced in 2012 was just meant to be a high-level analysis of the likely financial impact of self-insuring and whether it would be a good idea to explore further or not. And you've probably heard this study referred to because we still hear the numbers thrown out there today. It was a very wide-ranging estimate that ranged from potential cost savings to maybe this would cost quite a bit more for the program. And the reason that it was such a wide-ranging estimate was the fact that Deloitte had very little concrete data to evaluate it. They were just looking at other states and other models and coming up with a high-level analysis. And the key recommendation that came out of that was a more detailed financial analysis would be required to refine that cost savings estimate. So that's what we did. And so the next bubble you see there, August 2013, was the next Deloitte presentation to the Group Insurance Board. We spent the spring and summer collecting a more detailed, granular level of claims and cost information from our health plans so that, again, Deloitte could refine those estimates and come up with a better projection on cost savings or cost increases related to self-insuring. And so that was presented to our board in August, and in that fall, in October of 2013, the board took another look at the information and just felt that it was inconclusive. And so the direction they gave staff at that point in time was to do further analysis of our claims cost drivers in our program. Were there other alternatives to self-insuring that might also achieve cost savings? And so staff started to head down that path. The next bubble we have up there, January of 2014, as staff started to analyze the data, we told the board that we have a lean staff, and the expanded expertise of a benefit consultant with experience in other states, including states that self-insure, would really help us take a more thoughtful look at this information and make a more thoughtful recommendation to the board moving forward. And so we issued a request for a proposal or a competitive bid, and that is how we ended up with Siegel Consulting, won that bid and came on board in the fall of 2014 to help us with that analysis. And so, another way of looking at 2014 is while we were digging into data, hiring a benefit consultant, the self-insuring discussion was largely put on hold that year. So, fast forward to the deliverables we had from the Siegel contract. So again, they were hired to be a benefit consultant with two key deliverables. One was a near-term look at potential savings for 2016. And the second report was a more thoughtful, detailed, longer-term look at potential ways to restructure our program. Our contract with Siegel was very detailed, even though there's been a lot of focus on the self-insuring and regionalization of our program. Our contract with Siegel and their eventual report focused on wellness, disease management, prescription drug costs, a whole array of things that Siegel looked at and evaluated for the report that they put out in November of 2015. But I don't want to jump ahead. So in March of 2015, the first report just highlighted some short-term cost savings initiatives we could put into place, and also to maybe put it into the larger state budget context. Once again, that spring, the legislature was looking at a biennial budget proposal, and once again, specific savings for this program were included as part of the budget. So we knew we had to find ways to cut costs for 2016 because it was required in the budget. So then in August of 2015, looking ahead to that November report that was their second deliverable, Siegel issued another, we called it a request for information, but this was getting more sophisticated levels of data from our health plans to better inform the piece of their report that was focused on self-insuring. And then in November of 2015 was when Siegel released that second report to the Group Insurance Board. It is publicly available online and is 164 pages of page-turning thriller. So check it out. So let me just move along here. So I've talked a lot about the actuarial studies, and I wanted to do so because this is something that you see cropping up in the media, and the different projections. One says this, one says that, and so I just wanted to take this opportunity to clarify that yes, different estimates have been put out there previously, but what both actuaries agreed to was the fact that to get real, valid, binding information about cost and provider access and all the other important things we're talking about today, the only way to get real information was to do a formal request for proposal or competitive bid so that we could get the level of detail, the level of detail we were looking for so that we could actually come up with a thoughtful, well-informed cost estimate on what would this look like and would this in fact likely lead to cost savings in the state employee program. So that's kind of the history of where we've been, but let me talk about more recent events. So given the Siegel report in November of 2015, the suggestion that a request for proposals was the best way to get good, solid information. In February of 2016, we did go to the board with a recommendation to issue a request for proposal that looked at self-insuring. It also looked at regionalizing our program, and I'll talk about that a little bit more later in the presentation today. And what doesn't get a lot of media attention, a whole host of areas where we thought there were opportunities to improve quality in our program. So that was approved by the board about this time last year. Staff spent the first half of 2016 developing that request for proposals. We pulled in models from all sorts of states that have self-insured to help inform and help us develop our request for proposal. What we tried to do throughout, because we knew this would be controversial and there would be a lot of people interested in the outcome, we tried to make this as thoughtful, deliberate, and transparent as possible. And so in May, Siegel and ETF released, we called it a request for comment, but we basically put out there to our current health plans and other TPAs that might be interested in participating in this program. We actually sent out, here's what the regions look like that we're considering. Here's the way we plan to collect claims data as part of this analysis. Provide feedback. We wanted to make sure that how we were proceeding was feasible and logical and something that vendors interested in participating could do for us. So that was the first opportunity for comment. We followed that with, we called it a request for information, but essentially in June, we put out a draft of the full request for proposal or the full competitive bid for a couple of reasons. One was to get feedback again from interested vendors. Have we missed something? Are we asking the questions the wrong way? Are we asking you to provide information that is not realistic for you? So we did that to get feedback. The other benefit was that interested vendors had an early jump start to see what the RFP was going to look like and start to think about and develop their proposals that would be due later in the summer. And then in July of last year, we actually issued the RFP and put it in the field for interested vendors to submit bids. So then wrapping up 2016, those bids were due in September of last year, and there was a 2-month evaluation process, and this was a standard state procurement. So the evaluation team and then our consulting actuary had a piece of the proposal that they were looking at as well. They completed their analysis and evaluation at the end of November of last year. And that was the first time that the board had an opportunity to review the results of the RFP. As you can imagine, this was quite a bit of information to absorb, and so the board, not only did they meet for a full day at the end of November, we reconvened in mid-December for another full-day meeting, and then a final full-day meeting earlier this month at the beginning of February. And at each step in the process, we tried to come up with scenarios and options for the board considered and slowly vet down based on their feedback and interests. And so what the board decided on February 8th was that not only do they want to self-insure the entire state employee health insurance program, but they wanted to move to a regional structure in which for vendors to compete in our program, they had to cover entire regions of the state. And so the state is divvied up into north, south, east, and west. And how that's different than today, for those maybe unfamiliar, is right now we let our insurers choose where they want to bid on a county-by-county basis. So to make it more relevant, here in the Dane County area, you have a GHC that is really just Dane County, whereas you have Unity that goes quite a ways over to the east and quite a ways north and over to the west. Dean has a similar footprint to Unity, but just a little bit smaller in a few different counties here and there. So that's how it is today, but in this new structure, if you want to be part of the program, you have to cover the entire southern region in the case of the Madison area. I will talk about the other pieces of the timeline here in a moment, but next steps are negotiating those contracts, and then there's also a role for the legislature, but like I said, I'll talk about that a little bit more in a minute. So a few more things, I kind of cover this at a very high level, But in the RFP, there were a number of areas that vendors had to submit information on. I think the cost piece, because of the media coverage, is getting the most attention. Also, what their provider network would look like for 2018. Those are the pieces of the proposal that our actuary scored. But 60% of the proposal focused on more technical issues rather than cost and access. So things like their disease management approach, their quality improvement strategies, their customer service. The vast majority of the score for the RFP was weighted on those sorts of considerations. And again, this is all available online if you are having trouble sleeping some night. Every single section of the RFP, it is several hundred pages long, but it is all publicly available. So I just touched on this a little bit briefly. Again, just wanted to emphasize the fact that there are different sections of the RFP and how they were weighted. So the 20% that's listed up there are things like, do you have the capacity to serve a client of our size? What would your account team look like? What could be the expected frequency of interaction with our account lead and that sort of thing? And then when you get more of the technical things, that gets into the wellness and disease management, quality improvement initiatives, and those sorts of things. And then that final piece is where Siegel looked at, what are your administrative costs? What would our claims have cost given the discounts that you have in place with your provider networks today? What does your provider network look like, and how does that compare to the providers that are available to state employees today? And so that was another 40% of the overall score. Which brings us back to the decisions the board made on February 8th, just a couple weeks ago. So as I said before, they did decide to self-insure. We have 4 regions, so how that will work is in certain regions we'll have 2 competing vendors. In other regions there will just be 1 regional vendor, and then there is an overall statewide, nationwide vendor. And the board, we presented several options for implementation timelines, so one being January 1 of 2018. We also asked if they wanted to consider a mid-year change, so July of 2018, which would align with the state fiscal year, or move it out to a January 1 of 2019. And as you can imagine, the pros and cons of those different approaches are pretty intuitive. The sooner you implement it, the sooner you can potentially experience the cost savings, whereas the more you delay it, the more you give time to ensure an absolute smooth transition. So it's that balancing act that the board weighed when they decided that they wanted to proceed for January of 2018. And so I will get into Medicare in more detail later in this presentation, but I don't think these decisions have received as much attention as maybe the overall self-insuring and regionalization pieces. So the good news is that for 2018, the board said we want all the options that are available to our Medicare retirees continue to be available for 2018. And I don't want to presume that everyone is aware of all the different Medicare options available for state employees, so I'm going to go over those quickly later in the presentation. But basically the board said the Medicare supplement that is currently administered through WPS, they want to continue to administer through the new statewide vendor. The Medicare Advantage plan that is administered through Humana will continue to be administered through Humana for next year. Something that's not bulleted up there, but the general It's Your Choice Medicare that you can choose through the health plans that you had as an active or pre-Medicare retiree, that option will continue to be available. And like I said, we'll get into that in more detail in just a moment. In addition to that, the board asked that we come back at their May meeting this year with additional analysis and recommendations on Medicare options for 2019 and beyond. So staff are continuing to analyze that now. So we touched on this a little bit on the timeline, but the board decision is not the last step to implementation, not even close. So the next steps are contract negotiations, and we actually kicked off those negotiations with the winning TPAs in the bid this week. And we've let them know that we would like negotiations to proceed pretty quickly because of that next step that's listed up there, legislative approval, that I'll talk about on the next slide. And also, I'm going to go into how we are going about the tiering and setting the premium rates, and finally, our communication and outreach strategies. So there are several large initiatives that have to occur between now and January of 2018 for this to roll out successfully. So I mentioned negotiations are underway, and we're going to do our best to try to wrap those up in the next several weeks. And part of the reason, or the driver behind that aggressive timeline, is the fact that we have this next step after negotiations are complete. So last year, or I guess it's a little more than a year ago, the legislature passed a law that says in the event that the state is ready to self-insure any aspect of the health insurance program, it is required to go to the Joint Finance Committee for what's called a passive review process. And again, I don't want to presume that everyone's enough of a nerd like me to know what that is, so I will explain it really quickly. So passive review, it's a 21-day process where any member of the committee can file an objection. In the event that they do that, the committee can meet, they can hold a public hearing, they can ask ETF to come in and present our proposal and how we got to self-insuring. But all of that doesn't need to occur within the 21 days. 21 days is just the timeline for noting that objection to this proceeding. So that's a long way of saying after this proposal gets to the Joint Finance Committee, it is a little bit unknown on the timeline, the next steps, and it's a bit out of our control. And so that is why we'd like to complete the contract negotiations in the next month or 6 weeks so that we can kick off that step of the process. And we have let the Joint Finance Committee know that for this to be a smooth transition for 2018, we really need a decision by May, because there are not only IT system issues involved, but the member communication piece, which is going to be unprecedented if we are shifting to a new structure for 2018. The last item I have up there, the not approved box, this is absolutely a possibility. The Joint Finance Committee could choose to reject any or all of the self-insured contracts. And so in the event that that happens, or even in the event that we get to May and it's unknown how the Joint Finance will decide on this proposal, we will have to kick off our regular negotiation process as we would in a fully insured environment, just to be prepared for whatever comes out of the legislature. So just thought there might be questions about what if this doesn't go through, and I want you to know everyone stay healthy is not the campaign for 2018. We do have to administer a health insurance program, whether it's fully insured or self-insured. So tiering and premiums, I know the tier structure, which determines the active employee premium share, is probably more relevant for our active employees, but I just wanted to highlight that there is no plan to change how we've approached this in the past. We're still going to put the plans in tier 1, 2, or 3. Active employee premiums will be based on that. Our timeline and process to announce rates and premium levels is the same as a typical year, so that would still be, August, September, board approval, and putting it out there before your fall enrollment period. I should hit on the last bullet. So this is a small sliver of our program, but I think it's still important. So right now, our statewide, nationwide plan that it used to be called the Standard Plan. It's now called the It's Your Choice Access Plan. It's administered through WPS. That contract is running out at the close of 2017. And so the new statewide, nationwide vendor, which is Anthem, will be picking up that contract. And something that we'd like to do as part of this change is make that offering more competitive than it's been previously. Right now, it's a tier 3 plan, and to translate that into English, it means it has the highest employee contribution level, the highest premium level, and what that has done since it's been tier 3 for several years is it's really deteriorated the risk of that population, made that plan become more and more expensive year after year, and made it a really unattractive option for most of our members. And so what we'd try to like to do is get that statewide, nationwide plan off on a good competitive foot so that it attracts a broader risk profile and maintains a affordable premium rate longer term. So we're working on that today, but I just wanted to mention that. Okay, this is the important part. How does this affect the people in the room? So let's start with the pre-Medicare retirees. So this is pretty straightforward. Everything I've mentioned for active state employees is what impacts you. So moving from the different insurers competing on a county-by-county basis and moving to a self-insured regional structure, that will apply to you as well. You'll still be part of the state employee pool. Your premiums will be established, as I was saying earlier, in the same fashion that they have in previous years. And some of these little bullets up here were mentioned in the little video snippet, but what we're really aiming to do with this restructuring is not just cost containment, but take advantage of opportunities to improve the quality and maintain access to your doctor. So we haven't talked about the vendors by name yet, and I wanted to spend a little bit of time on that. So I have mentioned the fact that we have a statewide, nationwide vendor that will be Anthem. In addition to that, I did mention that we divvied the state into 4 regions, but let's talk a little bit about who the actual winning third-party administrators were in each region. So in the north, it was Security, which is a homegrown Wisconsin plan that participates in our program today. They won the north region. In the west, it's Health Partners, a Minneapolis-based insurer that also currently participates in our program, so that will be the coverage for the western region. Over in the east, it's Network Healthcare, which is out of the Fox Valley and has been a long time participant in our program, alongside Anthem. And maybe just to clarify the difference between the Anthem statewide network and what's available in the east, Anthem has proposed a narrow network affiliated with the UWRA health system in the east. So it will be a narrow network, a more affordable option that we're going to pilot over in the east region. And then here in the south, I leave the most important for last. We have Dean, which I'm sure you're all familiar with, and also Quartz. And I'm not sure if everyone is familiar with who Quartz is. This is a partnership of Unity, which I think you're probably familiar with, and also the Gunderson Health System out of the La Crosse area. They had very publicly partnered, it's been over a year now, and they are formalizing it in this self-insured TPA. A couple of other things that are important to the Quartz proposal is the fact that P+ here in the Dane County area has also very publicly been exploring a partnership with that organization. And so word on the street is that that partnership could be or should be finalized this summer. So it's likely that the P+ network will also be available under that Quartz umbrella. And finally, some of you maybe saw the news story a couple of weeks ago about GHC here. The GHC providers are also largely available through the Quartz network. So while GHC and P+ may not be there as insurers, the providers that you're used to having access to through those health systems will be available. And I'm sure there'll be more questions on that in the Q&A, and I'm happy to go into detail with your questions on that. But I just thought, at least at a high level, that would be useful information for you to know. So provider access, this was mentioned again in the e-learning video, and I talked about it a little bit in the proposal scoring piece as well. But I wanted to clarify, where does this 98% access number come from, and is it believable and real? And it is. So in the request for proposal, what we did for all the bidding vendors was we sent out our current providers. There's a national provider identifier number, and we asked each of the bidding vendors to tell us which of these providers are going to be available in the network you're bidding for 2018. And they had to indicate which of the providers were going to be in network and available. And the answer is 98% of our current providers are covered in those networks through the TPAs that I highlighted earlier. In addition to that, and we haven't been talking about this as much publicly, there are actually going to be more physicians available than there are in the current networks today, because some of the proposing vendors had much broader networks than we've seen traditionally from them. So that's also good news. And this is just one little bullet on a slide, but I think that final piece about providing you all information is what keeps most of my staff up at night. As I said earlier, this communication effort is going to be unprecedented, and doing it right is going to be crucial so that you all are able to say, okay, I have Dr. Smith, I want to stay with Dr. Smith. What insurer do I need to enroll with to make sure I have Dr. Smith in 2018? And so that communication piece is very front of mind to staff, and as we get through each step in the process and continue to expand our communication effort, that's what we'll be doing in 2018 so that you are well informed by the time the enrollment period rolls around this fall. So that is what I was planning to cover on the pre-Medicare retirees, and I just wanted to flip to the Medicare population next. So for starters, I think what's most important that I mentioned earlier is your options that are currently available will still be available in 2018, which is great news. But as I also said earlier, I don't want to presume that you're all familiar, and I thought it might be worthwhile to talk about the 3 Medicare options and just generally what they are. And again, in Q&A, if you have more detailed questions, we can talk about it. But we also brought materials today to show benefits comparisons, so that hopefully will be helpful as well. So the first one listed here, the It's Your Choice Health Plan Medicare. So this is the plan that offers the same uniform benefits that you're used to as an active or pre-Medicare retiree. It also is administered through the health plans that you're used to having today. So if you're in Dean as a pre-Medicare retiree, you can stay with Dean for this benefit. And it's coordinated with Medicare, which means Medicare pays first, and then this plan picks up anything not covered by Medicare that falls under uniform benefits. This is also far and away the most popular offering we have. About 60% of our members are enrolled through those plans. The second is the Medicare Advantage. We've had this for just a few years. It's currently administered through Humana, and this also offers the uniform benefits package that you are used to as a state employee or a pre-Medicare retiree. What's different about this is that it gives you nationwide access to providers that accept Medicare. And so the benefits are largely the same, but there's that nationwide access that makes the Medicare Advantage plan distinct. The final offering, It's Your Choice Medicare Plus, is the only supplemental Medicare offering that we have today. It's currently administered through WPS. It is, you may have heard the term a wrap benefit. So basically, it covers the same as Medicare, but essentially fills holes like deductibles and copays. And since it is a more limited benefit, it also is the most affordable of our options. And it also has nationwide and, if you're traveling, worldwide access, which is also attractive to some of our members. And so that is our second most popular plan. We have about 30% of our members choose a Medicare supplement for their coverage. So those are the general Medicare options, but let me talk about what's staying the same and what's changing for 2018. So let's go in the same order, starting with the It's Your Choice Health Plan by Medicare. So the benefits are staying the same, but what's different, and this is the same as the pre-Medicare retirees that we were just talking about, the structure will mirror what state employees have. So the health plans that we just talked about, or the TPAs we just talked about a couple slides ago, those will be the TPAs administering this benefit for 2018. The second category, the Medicare Advantage plan, this is not changing at all. Humana is the current administrator. The board approved continuing with Humana for Medicare Advantage for 2018. And finally, on the Medicare Plus supplemental option, I mentioned this a little bit earlier, but our contract with WPS does wind down at the end of 2017, so we did need to replace that, and so the new statewide nationwide carrier, Anthem, will be administering the Medicare supplement program for 2018. So, I can't emphasize this enough. The information campaign is being currently worked on by our staff. We already have tried to get out in front on member questions, and we have a frequently asked questions section on our website. The online video that I showed you is another communication tool that we're trying to use, but just getting out to groups like this, every presentation we give gives us more questions we should be adding to the mix and addressing so that our members know the answers. So information, like I said before, is very front of mind and is going to be, I think, the most crucial task for us in the time ahead. So finally, we wanted to have a slide on this so that you actually had it in your slide deck, and I know these are going to be available online as well. We just wanted to share some reminders about where you can get help and advice and information about Medicare. The Medigap helpline is very useful, or if you prefer to talk to ETF directly, our Ombud staff is also very knowledgeable about our Medicare options and can also help guide you. So that information is just for your reference. So we've talked a lot about 2018. I just wanted to have a brief slide on what are we looking for 2019 and beyond. Something I did not mention in talking about the regional self-insured program is that we actually are looking to negotiate 3-year contracts with those TPAs. So rather than changes year after year, we'd like to have some stability both in terms of cost, but also in terms of the carriers that are available. So we are aiming to lock into contracts that would take us through 2020. So that's important. We also, I mentioned this a little bit in the Medicare section, the board did ask us to come back with additional information about Medicare options for 2019. In particular, and this was a recommendation that came out of the Siegel report, they really would like to explore further expansion of Medicare Advantage offerings. Right now, as I mentioned before, we just have the Humana Medicare Advantage plan, but they're very attractive in that they tend to be a little more affordable than what most of our members have through our regional health plans today, and it provides nationwide access. So the board's asked us to bring back options to see if expanding Medicare Advantage options for our members would be a good benefit to offer. So that's, out of all of these, that's probably the most relevant for this population. And like I said, we'll be bringing that recommendation back to the board in May. So there are lots of ways to stay connected to ETF and get information about your benefits. Nancy Ketterhagen from our staff is probably tweeting in the room somewhere. There she is. So there's Twitter, obviously our website. We have regular, you can sign up for, they're called Gov Delivery, but you can sign up to be on a listserv so that as news happens at ETF or information becomes available, we push that out through those email updates, and then obviously you can call us as well. And as I've stated a couple of times today, as we go through the year and more information is firmed up in concrete, there will also be, hard copy, mail materials. We'll be working very closely with our new carriers to make sure we're pushing out information well in advance of the fall enrollment period. So again, you're well prepared by the time that rolls around. And that's all I had prepared, so we absolutely can take a break. I'll turn it back over to the man with the mic.
Thanks, Lisa.